Thanks very much. I think it's a little daunting to get in front of a group of peers like this who deal with this every day, the solitary pulmonary nodule, to give a talk to you guys about solitary pulmonary nodule. To me, it's kind of like going to the Oscars and telling them how to make a movie. I mean, this is something that you guys do every single day. And so what I'm going to try and do is put some sense into what I do, and hopefully that will give you a chance to identify things that you may want to change or maybe confirm what you're doing. Again, as a sense of my humbleness, back at the registry 9 years ago, this same talk was given by 3 more eminent people than me. And so I'm going to give you this talk in 1 session rather than 3 today, and hopefully give you some of the same perspectives, but some of the more up-to-date perspectives now 9 years later. My disclosure, I won't be talking about this, but I have a patent on minimally invasive brachytherapy delivery device, and so that won't be the subject of this talk, but it's in my disclosure. You've just heard some excellent talks by Dr. Aberle and Dr. Colby about this lung cancer screening and adenocarcinoma in situ, and you may be thinking that there's going to be spots and nodules appearing everywhere and what to do about them. Well, I'm going to try and give you some sense about what that is, and after hearing from Dr. Aberle, this is maybe what you might predict, given the fact that there's a 6.7% all-comer improvement on mortality. That could be what we expect, and there may be an avalanche or a tsunami or tidal wave of nodules coming our way, so we better have a better way of dealing with this. What we got from Dr. Aberle's talk was issues of screening, and this is a concept that Linda Martin introduced to me a couple years ago at the Southern, and I think it really graphically depicts some of our issues with lung cancer screening. That developing a screening program is like deciding you're going to pick your nose in public. You better know ahead of time what you're going to do when you find something. And what that does is I think it really graphically depicts our conundrum and what is at the basis of a good screening trial. It's not just, as Dr. Aberle said, it's not just a CT scan. It's a procedure. It's a process rather than a procedure. And what makes a good screening program is not just the actual test, but it's what we do with the results of that test and how thoughtful we are with that. And it comes to the 2 things that I think make up a successful screening program. One is to accurately determine your population at risk. For the longest time, we were faced with people saying, well, you can't do lung cancer screening because you've got to screen everybody. Well, that doesn't make any sense whatsoever. We wouldn't screen women for prostate cancer. You want to pick your groups with high risk. So if you cast your net too broad, you're going to have increased false positives. If you cast your net too selectively, you're going to decrease your overall benefit. And the second part of a successful screening program is developing a protocol for the identified cases. Know what you're going to do when you find something. So let's define the solitary pulmonary nodule, which is what my task is to talk about today. And I won't define it. The Fleischner Society, a group of eminent physicians around the world, have defined it, and we have a member of the Fleischner Society today, Dr. Colby, and a number of our GTSC members are members of the Fleischner Society. Larry Kaiser, Joel Cooper, and some of our international thoracic surgeons, Paolo Maccarini, are members of this. And what they defined the solitary pulmonary nodule in an effort to be able to hone in on the discussion was as a single, sharply defined circular opacity that's 2 to 30 millimeters in diameter and completely surrounded by lung tissue without associated atelectasis or lymphadenopathy. I think it really well defines the issue of a solitary pulmonary nodule. Now, not everything that we see is a solitary pulmonary nodule, but in terms of discussing this, this is the frame of reference that we're given. What it excludes are pulmonary masses, lesions above 3 centimeters, which clearly have an increased risk of being malignant, linear scar lesions, lesions with lymphadenopathy, again, which changes your pretest probability, and chest wall lesions and multiple lesions. So what we're talking about is solitary pulmonary nodules as defined above. And again, it's with humility that I present to you some of this data which you all know very well. there's about 150,000 new SPNs found each year, and that's going to increase with the screening trials and the more free use of CT scans. 50% of smokers over the age of 50 years old will have at least one lung nodule, and the incidence of cancer varies. Also, benign lesions mostly are granulomatous disease, and some are hamartomas, but this proportion varies by region. In the Mayo Clinic lung cancer screening trial, again, this was 1,520 smokers with 3 annual low-dose CTs. These were patients over 50 with an over 20-pack year smoking history. Of those 1,520 smokers, we had 2,832 non-calcified lung nodules. And only 36 of them were lung cancer. So clearly we have to understand what we're going to do when we find these, either in screening trials or as the patient comes to your office with referred on because of a finding of a solitary pulmonary nodule. And here's the balance: an aggressive diagnostic approach versus a conservative diagnostic approach. And we get into those terms that we were introduced to earlier in the talks of the risk of overtreatment versus the risk of underdiagnosis. And we have to decide which side of this scale we're going to be on and how we weight each side. And we'll discuss how we get to an answer to that in the next few minutes. I mean, we all do this. Blink is a book by Malcolm Gladwell, which described how we take all of our life experiences and all of the knowledge that we've acquired, and it's maintained within the deep recesses of our brain, but we're able to access that in quick fashion when we see an issue. When in a blink of an eye, we're able to make a diagnosis and say, yep, that's a patient I want to operate on. That's a patient I don't want to operate on. That's the foot of the bed test. And the same thing with pulmonary nodules. What I'm going to show you today is that we don't do a bad job with this, and maybe maybe the idea is not to get away from the blink or the inspiration that we have from all of our experience that we've accumulated, but to put some numbers behind that so that we realize that yes, we actually are doing a good job for mathematically good reasons. So when you're doing a diagnostic workup of the solitary pulmonary nodule, there are patient-specific risk assessment that has to be done, there's nodule-specific risk assessment that must be done, and there are adjunctive tests. We'll go through these one at a time. In terms of patient-specific risk assessment, one of those issues is age. We know that with increasing age, the risk of that nodule being malignant is greater and above 50% in the patients who are over the age of 60. So age is something that we factor in almost unconsciously, most of the time unconsciously. And other patient-specific risk factors or criteria within our own risk assessment are history of smoking, family history of lung cancer, previous malignancy, and things like asbestos exposure or radon exposure, things like that that are a little less obvious and a little less prevalent. But those are all the factors that we need to put into our risk assessment from a patient-specific standpoint. They're all very important, and they all help to develop that pre-test probability. So there's something we face, this nodule sitting out there in the mid to peripheral lung, and we all can look at that, and everyone in this room has determined in their head already what they would do with this nodule. But can you describe why you've chosen that? Can you verbally express why you've chosen to do the pathway you've chosen? No. You know it because you may not be able to describe it, but you know it when you see it. And this is a concept that was introduced to us by Associate Chief Justice Potter Stewart of the Supreme Court back in '64 when he was dealing with a case not of lung cancer but of public lewdness. So he knew it when he could see it, and I think we know it when we can see it, but we sometimes don't know how to describe it. So let's talk about some of the nodule-specific factors that help us to determine whether this is cancer or not. Well, one of the issues is size. Again, similar to age, size is one of those things that we understand very well. With increasing size, the likelihood of malignancy increases, and it increases almost exponentially. Other nodule-specific risk assessment tools are size, border, calcification, density, growth, And all of these are the things that we take into account when we make that determination every day in managing our solitary pulmonary nodules. And I'll speak to growth. The most important thing that we can do when we first see a patient with a solitary pulmonary nodule is look for prior imaging studies, because it allows us to do a retrospective surveillance study on that nodule. And I think it's very important to always seek out the prior imaging studies if they are available. The issue of growth rate is demonstrated here. Depending on the nature of the lesion seen, there's a different likelihood of this being cancer, and there's different tumor doubling times. With a pure ground glass opacification, the tumor doubling time is in the range of 800 days. When there's that sort of, as the Dr. Tsuchiya said in Japan, that sunny side up, that mixed solid component in GGO is somewhere in the range of 400 to 500 days. And then a solid nodule clearly has, that's malignant, clearly has a tumor doubling time that's much quicker. And the idea of tumor doubling time, we all understand that, but in order to explicitly say it, this is the volume equation for a sphere, which is what we sort of extrapolate these nodules to be. The important thing to remember in that is as the volume doubles, the diameter doesn't have to double. Going up 30% in diameter really is what increases your volume by a doubling component. So just going up by 30% in the diameter, which is what we measure in the 2D world of CT scans, is indicative of a doubling of the volume of the lesion. So there are patient-specific factors, and there are nodule-specific factors that we all take into account when we try and determine what's going on, and they all have their different coefficients. And you can do a quantitative Bayesian model which looks at all the likelihood ratios, putting all of those factors into it, and it's been done. You know, the odds of malignancy using the likelihood ratio of prevalence in your community and size of the lesion, the age of the patient, and smoking history, and so on, leads you to then creating a probability of malignancy, which is odds over 1 plus odds. And in a different way, this was Steve Swenson from the Mayo Clinic's publication, where he looked at the probability of malignancy using the different coefficients of age, smoking history, cancer history, and diameter, and spiculation, all of these things. And it's doable, but you probably need an app to do that. And before you go out and either create or buy an app on this, I think the one thing to remember after discussing that there is science and there's numbers behind these likelihood ratios and our ability to make the determination of a solitary pulmonary nodule being malignant or not, I just point to this. The likelihood ratios for size above 3 centimeters is about 5. Spiculation is about 5. Doubling time between 7 days and 465 days is about 3, and age above 70, the likelihood ratio is about 4. So these are all the coefficients to take into account. In the same study, the surgeon's gestalt, or the radiologist's gestalt, had a likelihood ratio of 37.2. So I go back to the blink issue, that our impression is pretty good. And the collective experience in this room, I would stand behind and say we don't need an app. We do a pretty good job. Let's look at some adjunctive tests. And when you already say that we do a pretty good job, what do we need these adjunctive tests for? And I'd say that they're of limited value, in fact, but they are part of our armamentarium. PET scan. I'm not a real big fan of the PET scan, and I remember back 9 years ago, Joe Schrager discussed it, and he wasn't a big fan of the PET scan in terms of the solitary pulmonary nodule. It has its role, and I think the problem with it is that what do you do with the result? And so much of the value of the PET scan is lost in the fact that we either go into the PET scanning machine with a high pretest probability or a low pretest probability that the value of the PET scan in changing that is very low. It has a very good sensitivity for nodules above 1 centimeter, but its specificity is sort of marginal. And the false negatives are real. Small lesions, low-grade tumors, such as adenocarcinoma in situ. I know I have BAC up there. And it's got false positives as well, especially in the upper Midwest. And Kent Kernstein has written on this in the mediastinum, but in the nodules in the upper Midwest, we have granulomatous disease. In Germany, they have silicosis. And so the PET scan can be erroneously positive. So a negative PET doesn't rule out cancer, and a positive PET requires tissue confirmation. So in that regard, you have to take the PET scan and understand its downfalls or its limitations. Looking at transthoracic needle aspiration biopsy, what we call TTNAB at Mayo, basically percutaneous biopsies. There's CT-guided FNAs, and now more and more we're seeing CT-guided cores done. Sensitivity, it's dependent on the size and location, and it's mostly used for peripheral nodules. It's operator dependent, it's very operator dependent, both in the CT interventionalist as well as the cytologist. And I'm Canadian, so I'm very proud of the fact that there's some value up in Canada of having a difficulty of getting to the OR. In Ottawa, they've gotten very good at picking out these nodules because they've got a good experience of doing percutaneous needle biopsies. The pathologists, the radiologists are very good because it's difficult to get patients to the operating room, and so they find that this is a useful tool in their workup of the pulmonary nodule. Decreases their number of patients that they bring to the operating room for benign lesions. But it's highly specific, but it's also very operator dependent. Bronchoscopy, mostly for centrally located nodules. Its sensitivity is dependent on the size and location as well. And conventional bronchoscopy is good, but 20% of the lesions in the outer third, you can't really get there. It's dependent on the bronchoscopist as well as the cytologist, and some places have developed a good skill with this. Now it's highly specific as well. Now we have EBUS, which helps to guide us, as well as some electromagnetic guidance systems. And I won't go into detail about this, but it's a really neat use of electromagnetic guidance. Whether or not it's going to be an important adjunct to what we do in determining the value or the diagnosis of these peripheral nodules is still to be seen. So at the end of our toolbox of things that we can do, adjunctive measures for looking at diagnosing a solitary pulmonary nodule, is the excisional biopsy. And for years this was looked on, especially by our pulmonary colleagues, as the failure of being able to diagnose when we had to get to this stage. And it was mostly because this is what we were managing. Patients ended up with a big, huge shark bite and chest tubes and the morbidity associated with it. But now, I put it to you that excisional biopsy is not the same as it was before. It's not as it was in 1900 with the Tour de France. It's now a much more elegant and less morbid procedure. And I think it is definitely within our useful armamentarium when dealing with the diagnosis of a solitary pulmonary nodule. So thoracoscopy with excisional biopsy, mostly for peripheral nodules. It's minimally invasive, it has low morbidity and mortality, and we all in this room can agree on that. It has a high diagnostic accuracy because you're getting the lesion itself and letting the pathologist look at it all. And it's cost effective in high likelihood cases. When we use our judgment to pick the right patients for this, it's highly cost effective. The cost per correct diagnosis of a solitary pulmonary nodule, well, when you use percutaneous biopsy, it's $21,000. For bronchoscopy, it's $16,000. And for surgical excision, it's $13,000. And that was back in the late 90s. I think we've been able to do it much more cost effective now with expertise and VATs going up. Unfortunately, this is a slide that gets put out to our other colleagues. This is a slide from one of our own Mayo pulmonologists, and basically telling us that we're taking out too many benign nodules, quoting very selectively from the literature of a paper from Italy or some papers that are relatively unrelated, and telling people to take home message that between 50 and 86% of nodules that are being removed are benign. I think that's an unfortunate distortion of the reality. When you look at the screening trials, benign nodules accounted for 18% in the Mayo Clinic screening trial, 22% in the Diedrich trial, and you go down the list and it's somewhere between 18 and 30%, which is not 50 to 86%. And I think it's important that we get that message out. We do have to decrease the rate of benign lesions that are removed because that'll decrease the morbidity. But I think it's just like with appendectomies, if you don't have a certain percentage of benign lesions, you're probably leaving in some malignant ones. So it's not 50 to 85% as being quoted out there. It's much less than that. It's our job to use judgment to keep that number down. When we talk about number needed to treat in terms of surgical excisional biopsy, we look at Avandia to prevent MI or other complications is about 1,000 in the number needed to treat. A statin to prevent death is about 500. A statin to prevent MI or CVA is about 250 number needed to treat. Now, H. pylori, you need to treat 5 patients in order to heal an ulcer during that treatment regimen. So, excisional biopsy to diagnose and possibly treat a lung cancer. Well, even if we use the statistic of 50% of the nodules being benign, then that brings our number needed to treat to 2. So that's not a bad statistic, and I think we do a pretty good job. So looking quickly at a solitary pulmonary nodule algorithm, the first thing to do is to assess the risk, both patient and nodule-specific risk assessment. And that'll give you a high suspicion of malignancy or low suspicion of malignancy. Just as Dr. Aberle said, we have a dichotomous decision tree, and this is what I do. I look at that. The high suspicion of malignancy, it's either a peripheral nodule, which is VATS accessible, or a central nodule with somewhat more challenging excisional biopsy. If it's a peripheral one, and my suspicion is high, I'm going to wedge that out by VATS and add a lobectomy if it's an invasive lung cancer. If it's a central nodule, these are the ones that you'll either do a biopsy or a bronchoscopy to get a tissue diagnosis earlier. And adding to that either a VATS lobectomy if it's a cancer. For the low suspicion of malignancy, this is either CT surveillance, as we've discussed, or biopsy if the patient's angst is elevated. Looking at the CT surveillance quickly, the Fleischner Society does have recommendations, and you get that at the end of your CT reports all the time if they're done correctly. And I won't go through it, but there's a low risk and high risk dichotomy there as well, and it gives us instructions on how to do CT surveillance appropriately. So we are going to see more nodules. There will be a tidal wave of more nodules, and the idea here is to take the high ground and decide how we're going to manage these with some degree of judgment and lucidity. I'm very proud that we're developing a lung cancer screening program at Mayo Clinic based on the National Lung Cancer Screening Trial, and it's a multidisciplinary effort amongst the pulmonologists, radiologists, pathologists, oncologists, and surgeons. And it looks at risk assessment, first and foremost. Determine the patients at risk. Don't cast the net too wide. Formal counseling of the results. This is a process, not a procedure. It involves smoking cessation because these are the main people who we're managing. And there's a protocol set aside for managing the findings. Know what to do when you find something. So in summary, when you face the solitary pulmonary nodule, and again, it's with humility that I say this to this group of people who manage this every day, obtain and compare your prior imaging, know your risk factors, both patient-specific and nodule-specific, and know the advantages and disadvantages of the available diagnostic tests. So I haven't addressed this directly. The elephant in the room is clearly SBRT. And I think that's open for discussion, and it's a valid thing for us to discuss in the future of how SBRT finds its way into the management of solitary pulmonary nodules. I think all of us in this room have a similar opinion, I'm sure, but it's worth a healthy and good discussion. It's not the basis of my talk. So, the solitary pulmonary nodule in a surgically fit smoker should be considered for aggressive diagnostic workup. This best serves the patient with a high likelihood of lung cancer and a high likelihood of a curative treatment. Thanks. It's nice to be able to get out of Minnesota, but I do understand that it's with some humility that I'm up here, and having your moment in the sun isn't always a good thing. But I appreciate it, and I look forward to a good discussion in the rest of the meeting. Thanks.